Terrific. Thank you very much. And thank you also to the academies and the Robert Wood Johnson Foundation and Jim Weinstein, who headed up this large panel. And I think that's one of our distinguishing features. Where am I pointing? Go, whoa, I got a little enthusiastic there. We could just advance one. As you can see, it's a large committee, and what brought energy to the committee was the fact that we had such breadth of experiences and expertise around the issue of health equity and community-based solutions to improving it. We had a charge which was to review the state of science around health disparities in the United States, focusing on root causes. An exciting dimension of our work was to examine at a minimum of 6, we arrived at 9 examples of community-based solutions to address the health equities, to delve into those and try to understand what some of the major elements of effective and promising solutions were. And then making recommendations, of course, short-term and long-term strategies and around research needs. We held 3 information gathering meetings. We received input from communities. I've noticed a number of our experts who were at our meetings here today. We held 5 deliberative committee meetings, and then we prepared our 9-chapter report, which of course underwent extensive peer review. The report layout is laying the foundation for what is the state of health equity, what do we understand about equity, its determinants. We delve into the phenomenon that health equity is in large part a result of poverty, structural racism, and discrimination, that communities have agency to promote health equity and have demonstrated that in the number of examples that we looked at. Of course, there is this surrounding policy that can help or facilitate community action. We delve then into the collaboration and engagement that's necessary, in our view, around promoting health equity, and then have an entire segment on tools and other resources that can help translate knowledge into action. We spent a considerable amount of time on this conceptual model, some of the elements of which may be familiar to some of you. It is circular, reflecting the nonlinear relationship between a number of these factors. The bedrock really is the idea that these structural inequities and biases and socioeconomic and political drivers are there, and they are shaping the health inequities. There are a number of social determinants of health that we looked at, many of which are familiar. We added transportation because it's such a key factor in, as the landscape of areas changes, the role that transportation plays in improving access to employment and other services, and the way transportation can carve through communities as well. The context, of course, is that equal is not the same as equitable. And at this point, Jim likes to give the example of the size 10 shoe, which always startles me because I have absolutely no use for a size 10 shoe. But that is the point, that if you give everyone the size 10 shoe, they have a size 10 shoe, it feels equal, but it is in fact not equitable. So the extent that we distribute services and programs equally, that doesn't translate into equitable opportunities for individuals. These relationships, as I said, among the social determinants are very much nonlinear. Then we focus on the inside circle, which is what we found to be the key elements of community-based solutions. This idea of making equity a shared vision and value. The community started from there, that idea that they had a shared vision that they were driving towards, that they fostered multi-sector collaboration, and that they increased community capacity. They have investments in leadership in their community that help sustain not necessarily a program, but an effort around improving equity along a number of social determinants of health, which would translate to health equity improvements, which is the desired outcome. Echoing the foundation's desire to have more equitable communities in which individuals and families live, learn, work, and play. Jim Weinstein wrote a very moving preface to the report that echoes a Declaration of Independence and values that are deeply rooted in our society around giving everyone a fair shot. Of course, we fall short of that, and these are just some infant mortality statistics by race that just illustrate, of course, that the stark differences that we have in terms of health equity. and the notable patterns over time, so that we can't be complacent in the sense that this isn't necessarily improving. For some parts of our income distribution, life expectancy has risen, but for the other parts of the income distribution, there has been no increase. And that these are large differences. We're just not talking about small marginal differences between the highest income and the poorest income, or differences between life expectancy for men and for women. Geography matters, and of course in today's world we have the ability to create maps like this. We have both the computing power and the data to tell us that on the left we have New Orleans, on the right we have Kansas City. In the circles, those numbers are life expectancy numbers adjusted for age. But notably, in very close proximity, you can have 25-year differences in life expectancy within an urban area. In Kansas City, very close, you have a 14-year difference in life expectancy. One of our first conclusions is that these health inequities have profound implications for our nation, for our economic vitality, our national security. We can estimate the costs of health racial disparities and come up with numbers in the hundreds of billions. And we can also look at that we have a population that can't qualify to serve in the military. 75% of 26 million young Americans can't qualify due to a combination of persistent health problems, poor education, and so forth. So these aren't trivial problems. Furthermore, we conclude that the evidence is such that health equity isn't the result of individual choice or random occurrence. There are structures, historic and ongoing power structures and policies and norms in place that continue to drive these inequities. So one of our recommendations is around health disparities research, focusing on explicit and implicit bias. What strategies, what research can we identify? What strategies can we identify to mitigate it? And can we create multidisciplinary research teams, including non-academics, to make headway? A very exciting part of our report is was the fun we had going through more than 100 community examples and then selecting 9 of them to feature that were active community efforts to promote health equity. We ended up with a range of activities, of geography, of strategies. The key common characteristics they had is that they were targeting a social determinant of health, not health per se, but a social determinant of health. It could be youth violence, it could be food co-ops, it could be education, it could be economic development, housing, and as you see on the right, the primary social determinant is highlighted here. The energy they brought, the multi-sector collaboration was a common feature, the shared vision and value, as well as an effort to create ongoing leadership. Very different approaches for each of these. The guiding principles, they leverage existing efforts whenever possible. There was authentic community engagement in each instance. They were nurturing, as I said, the leadership for the future. They were flexible. They included non-traditional partners. These were not public health-driven efforts. Public health was at the table. They weren't driven or initiated necessarily by public health, in most cases not by public health. But their implications for health were profound, and they were all evidence-informed. Pass it on to you.
Okay, I'm going to continue with some of the conclusions and recommendations, but before I start, I just also want to add my thanks to Robert Wood Johnson Foundation and also National Academy of Medicine for being able to be a part of this study. And as Jim Marks said in his opening comments, the fact that a study around community efforts and health equity came from the national academies, I think was really groundbreaking in a lot of ways. And our hope is that this report will live on and be something that will be a living document for those who are really focused on moving this agenda of culture of health forward. So let me just say a few things about some of these, and this does not by any means cover all of the recommendations or conclusions. Allison started with some, but we wanted to highlight some of the ones that we thought really brought home some of the really salient and key efforts. So one, we talked a lot about the importance of enabling researchers to engage in this, and how important data was, and how important continuing to think differently about health research related to the social determinants. So one of our conclusions was the importance of enabling researchers to fully document and understand health equities with some of the following that we thought was necessary. First of all, expanding some of the current disparity indicators. As we were looking through this, we know that there's a lot of information on whites and African Americans, but if we really want to think about this more holistically, we have to have more data about that goes beyond those two groups where much of the research has been done. That our metrics aren't really adequate right now and indicators to capture the link between health equity and social determinants, and that we needed to really continue to push on the metrics and the indicators. We all know that what gets measured gets done, and by not having the kinds of metrics that are important for this, we think we don't have the kind of data or the kind of action that's necessary. That a lot of our discussions looked at the fact that we know that there are single social determinants of health that have multiple impacts on health outcomes, and that we needed to have more research that actually looked at that connection, so that when we're thinking about how you can have the greatest impact, you can look at where would you have where would you intervene, and what are some of the structural factors that do influence health in multiple ways, and increasing funding opportunities to develop and test some of these things. A recommendation that we thought was highly important was having a consortium that came together, that brought together public and private sector to be able to create a repository of evidence. Again, as we were looking at this, we realized that there wasn't a place that people who are interested in this could go to be able to share their experiences or gain from others' experiences. Another recommendation, looking at government agencies who are involved in planning related to issues like land use, housing, transportation, and other important issues, needed to really think about how what they're doing had intended or unintended health consequences much more. And this really just speaks to the importance of really thinking about how these sectors take health and health consequences into their planning and into their efforts. We spent a lot of time talking about how important prioritizing affordable housing and strategies that that mitigate some of the displacement that was talked about in the opening panel. Another recommendation was really looking at how important schools were, but how health agencies and health related systems could do a better job of linking with schools, so that schools had the kind of input and awareness of health needs, and that could be integrated into our education and education systems. And again, a lot of discussion about how important the role of educational institutions and schools are, but it's hard for schools to be able to understand what's going on in the health of the community if there wasn't a better integration of health entities with the school systems. A big one was looking at the role of health and health systems as important to anchor institutions within communities. And we know that health and health systems are using their dollars, their philanthropic dollars, their community dollars, but they aren't always thinking about how they could be impacting on the social determinants of health, looking at things like housing, economic development, and other things that hospitals and health systems could be using their dollars to influence. I see that we're running close on time because we want to have some questions. A big point, and it's interesting that so many people use Martin Luther King quotes. was how important civil rights and civil rights approaches could be used when we think about how do you address the social determinants of health. And we had a lot of discussion about bringing in civil rights approaches into this. Foundations and other funders, and obviously Robert Wood Johnson is leading the charge, but looking at how other funders could support community interventions that promote health equity more broadly. Won't go into all those, but looking at issues that we've talked about here, about how do you develop community capacity, how do you use the focus on other aspects of social determinants like education, civil rights law, enforcement, et cetera. So getting the funding community to embrace this notion of the broader needs of the social determinants in developing the culture of health. Again, a lot of focus on the knowledge base for informing and guiding communities, and looking at how do we make sure that researchers who oftentimes, particularly health researchers who get more medically focused dollars, are incentivized to do more work that looks at community interventions. We talked a lot about the anchor institutions, and anchor institutions are defined here as examples: healthcare institutions, universities, businesses that are based in communities, and others who employ residents. How can they play a much more important role in enabling communities and addressing determinants of health? And then I think, looking at the role of local policymakers. We talked about policies and the role of policy and policymakers to address some of the policies that look at the inequities of health. And then finally, I think this is the final recommendation, we looked at how the Community Solutions Council that had been signed by an executive order in the last administration, and we don't know what the fate of community councils will be, but these were councils this was a council that was set up to actually look at enabling communities more broadly, and looking at the way in which we build competencies within communities, and that those community solution councils could be used as a way of addressing these factors more broadly that look at the health and health inequities. So that was one that we thought could really make a big difference at a federal level and at a broad level, but we'll see how the Community Solutions Council fare, but using those as a way of addressing it. So those are just some of the recommendations that we thought could have a big influence in a kind of a bi-directional way. How are we getting health institutions to think more broadly about the social determinants, and how are we getting institutions that don't necessarily focus on health to think about incorporating health in their work more broadly? And we, again, welcome your thoughts and questions, and hope that this is a report that will contribute to the overall sense of building a culture of health.